Morning. Today we will learn about another form of COVID-19 treatment, the one that uses monoclonal antibody. First, I would like to explain about the antibody. Antibody is a protein that is a part of our immune system. Antibody is produced by lymphocyte upon first encounter with the pathogen. When attacked by pathogen, our body immune system will generate antibody as a defense mechanism toward the unfamiliar molecule. We call that one as an antigen from the pathogen. After that, antibody can act in numerous ways. Some will bind to antigen to prevent the cell entry. We call this one as a neutralization. Other antibodies work by causing the pathogen to clump together, preparing the pathogen to be engulfed by phagocytes. Besides that, some antibodies can activate complement system, then can act to kill the pathogen. Before we talk about the monoclonal antibody, let's take a look on the SARS-CoV-2 genome. As you might know from previous lecture, SARS-CoV-2 genome encodes for a structural, non-structural, and accessory protein. A structural protein made the other construct of the virus, as you can see on the picture on the right side. The four major structural proteins are spike, envelope, membrane, and nucleocapsid. The SARS-CoV-2 virus spike glycoprotein, which sit on its surface, function to facilitate the virus entry into the body's cells. Currently, all the monoclonal antibody for COVID-19 for which the FDA have issued emergency use authorization target the spike protein. So, what is monoclonal antibody? Basically, monoclonal antibody is the identical copy of the antibody that can target one specific antigen. This protein can be made in the laboratory through exposure of white blood cell to antigen. You can see the common pathway for production on the figure, where first the antigen will be introduced to animal, and then fusing the polyclonal B cell from the spleen to myeloma cells, resulting hybridoma cell will be then cultured, selectively separated, and continue to produce antibodies to the antigen. Besides the monoclonal antibody, we also have heard about monoclonal antibody. So what are the difference for both of it, and why monoclonal antibody is often chosen for treatment or specific disease? Polyclonal antibody bind to the same antigen, but can be different epitope, unlike monoclonal antibody. Monoclonal antibody is bound to the same epitope on its target antigen. Because of monoclonal antibody lack selectivity, or although the use of for the more general matter will good, this increase the chance for cross-reactivity. Another difference is the purity, where for the monoclonal antibody is often produced with high homogeneity, unlike the polyclonal antibody. That makes monoclonal antibody more expensive to make and require higher cost than polyclonal antibody. The US FDA has approved 4 monoclonal antibody treatment related to COVID-19 under the emergency authorization. The 4 are bamlanivimab, approved on November 9, 2020, but the approval was revoked up on April 16, 2021. Sotrovimab approved on May 26, 2021. The antibody cocktail casirivimab and indevimab guideline update on June 3, 2021, and the most recent tocilizumab, June 24, 2021. We will review this treatment one by one. Let's see this one. I will repeat it one more time. Monoclonal antibody for COVID-19 treatment. I've told you before that FDA has approved for monoclonal antibody treatment related to COVID-19 for emergency use only. The first one, bamlanivimab, but this is already booked on April 16, 2021. Sotrovimab, casirivimab, and indevimab, and tocilizumab. Let's see. The first, bamlanivimab, first approved as a stand-alone treatment and combination with atezolizumab. The target is a spike protein RBD of SARS-CoV-2. Usage of bamlanivimab, a single treatment with atezolizumab, has been suspended due to circulating gamma and beta variant of concern, which have reduced susceptibility to both agents and the side effect that outweigh the benefit. A second, sotrovimab. This monoclonal antibody was originally identified in 2003 from a SARS-CoV survivor. It targets an epitope in the RBD of the spike protein that is conserved between SARS-CoV and SARS-CoV-2. Authorized for emergency use for mild to moderate COVID-19 patient about 12 years by USA, Singapore, Italy, etc. Sotrovimab is not approved to be used for hospitalized patients, limited only for patients at risk for progression to severe COVID-19. A clinical study showed that sotrovimab 500 milligram for treatment resulted in 6% absolute reduction and 85% relative reduction for hospitalization among the recipients. Now let's see casirivimab and indevimab administered together. It's also called Regencov. This antibody cocktail is the combination of monoclonal antibody that targets spike protein RBD of SARS-CoV-2. From the FDA update on June 3, 2021. The recommended dose for this cocktail is reduced to 600 milligram casirivimab and 600 milligram indevimab, administered intravenously for the first usage. Additionally, if the treatment delay or for infusion is not feasible, this dose can be given by injection. Similar with sotrovimab, Regencov also can be used for mild to moderate COVID COVID-19 patient or older than 12 years. You say for hospitalization, my patent is still in a trial. From a double-blind, placebo-controlled randomized trial is shown that Regenkov give 3.3% absolute reduction and 71% relative reduction in hospitalization or death in outpatient with mild to moderate COVID-19. Now, the most recently approved is tocilizumab. This monoclonal antibody is also known as Actemra commercially. Actemra was approved for emergency use for COVID-19 treatment on hospitalization patient. This is about above 2 years old, different with sotoromimab and Regenkov that only administered to outpatient. Tocilizumab is given to in patients that receive corticosteroid, require supplemental oxygen, ventilation in any form, and ECMO help. Tocilizumab works by blocking the interleukin-6 receptor, one of the inflammation parameter. The data supporting this emergency use authorization for Actemra are based on for clinical trials, recovery, impacta, copacta, and remdecta. In recovery trial, studies show the probability of death by day 28 is 30.6% for patient receiving Actemra and 34.6% for patients with unusual treatment. Although promising, the challenge occur as we know that the thrombotic event is independently associated with mortality of COVID-19 patients, but recovery trial did not give data about it. So this result is still need to be part of a study. So in case of discussing monoclonal antibody, I would say this is still in a trial now on, but as far as I know, in some hospital in my area, especially in Rumah Sakit Universitas Indonesia, the doctor has already used this one to treat a COVID-19 patient. I think that's all for this morning. Thank you so much for your understanding. Again, thank you and stay safe.